Thank you very much for inviting me to present Clotting at the Limits, the NOAC Generation. I'm Sonia Anand, Professor of Medicine from McMaster University in Hamilton, Ontario. I would like to describe for you how really the anticoagulants we use today to treat patients with thrombosis have revolutionized our practice. We historically had used anticoagulants such as intravenous heparin, oral warfarin, and really these two agents were the mainstay of anticoagulant therapy for thrombosis since the late 60s, early 70s. When low molecular weight heparin was discovered, it enabled us to deliver an anticoagulant at a therapeutic dose by subcutaneous injection, which freed up patients from their intravenous requirement. And since the low molecular weight heparins, advances have been developed to allow us to give direct 10A and direct thrombin or 2A inhibitors, first being available parenterally, such as fondaparinux in the 10A category, and hirudin or argatroban from the thrombin inhibitors or factor 2A inhibitors, to the current state where we are using direct oral anticoagulants known as DOACs, sometimes referred to as NOACs, but they've been around long enough now that we don't need to say NOAC. And this includes factor 10A inhibitors as well as factor 2A inhibitors. Now, I mentioned that in my clinical practice, I have seen this transformation. So 25 years ago, when I was a trainee in thrombosis at McMaster, it was the norm if we diagnosed a patient with a DVT or pulmonary embolism or with acute coronary syndrome that we used intravenous heparin. This was a solution mixed up and required the patient be admitted to hospital. And although we initiated the oral anticoagulant warfarin, or shown here as Coumadin, it often took an overlap of up to 5 days until the INR was between 2 and 3, and we could stop the intravenous heparin. So often our patients were in hospital for 10 to 14 days with a diagnosis of thrombosis. Now today, we have a completely different way of practice. If I'm on call for the thrombosis service and I'm called to the emergency room to see a patient who has a new pulmonary embolism, as shown here in this CT pulmonary angiogram, or a new DVT, as shown here in this compression ultrasound, if they are clinically stable, vital signs stable, I can treat these patients as outpatients, directly sending them home from the emergency room using an oral factor 10A inhibitor, in this case, rivaroxaban. Now here is the coagulation pathways that we all learned in medical school, and superimposed upon them are where these direct oral anticoagulants are acting. I'll show you that heparin here having its factor 10A and 2A inhibition side by side with low molecular weight heparin, where that ratio changes slightly but enables us to use a smaller molecule that is injectable instead of intravenous. In blue, we see the parenteral factor 2 inhibitors. On this side, we see fondaparinux as a parenteral factor 10A inhibitor. And then we can look at the oral anticoagulants in addition to warfarin. So warfarin, as you know, inhibits factors 10, 9, 7, and 2. When we move to the 10A inhibitors, such as rivaroxaban, apixaban, edoxaban, the 3 most commonly used, you can see this directly inhibits factor 10A that then prevents the generation of thrombin. On the other hand, if we're thinking about directly inhibiting factor 2A, dabigatran is a direct thrombin inhibitor, which is oral. And then you'll see I've superimposed on top of that reversal agents for some of these direct oral anticoagulants. You can see for this one, the oral 10As, I haven't yet superimposed andexanet, although I'll speak about that. But for dabigatran, I have shown that there is a monoclonal antibody available to inhibit dabigatran if a patient on that medication is bleeding. So we have a number of conditions for which phase 3 randomized clinical trials have been completed, and we have good evidence that we can use direct oral anticoagulants to treat patients with the following conditions: deep vein thrombosis, pulmonary embolism, atrial fibrillation, coronary artery disease, peripheral artery disease, stroke prevention. This could be primary or secondary, with lower dose DOACs being used primarily, cancer-associated thrombosis, and other venous thromboses in different locations that can be treated with direct oral anticoagulants. However, not all conditions can be treated with direct orals, and we've learned this either from phase 4, when these medications are used out in the community at large, as well as from randomized trials, that DOACs should not be used in patients who have mechanical valves. Warfarin is still the standard of care, as it is for patients with left ventricular thrombus and antiphospholipid antibody syndrome. Here I show the most commonly used DOACs and some of their properties. So you see dabigatran, rivaroxaban, apixaban, and edoxaban. And you can see the conditions for which they have had large, robust randomized trials and now are indicated in most countries around the world to be used in certain conditions. And these include atrial fibrillation, acute venous thromboembolism, the secondary prevention of venous thromboembolism, as well as after orthopedic surgery, typically using a lower dose or prevention dose to prevent venous thromboembolism in a high-risk patient. And most recently, we have shown in a number of trials, such as the COMPASS and Voyager trials, that lower dose or 1/4 of a full dose of rivaroxaban used together with aspirin is effective in preventing major adverse cardiovascular events in patients with CAD and major adverse limb events, in addition to the major adverse cardiovascular events in patients with PAD. So this has really revolutionized our treatment for patients with PAD. And I'll come back to that toward the end of the presentation. You'll see here the mechanism of action, which I've already described. Renal clearance is important to know because a vast number of our patients have impaired renal function with a low creatinine clearance, or eGFR, and we have to be aware which of these DOACs can be used in certain patients based on their creatinine clearance or renal function. The half-lives for these are generally quite consistent, between 8 hours for the 10A inhibitors, slightly longer for edoxaban, and 7 to 17 hours in patients who receive dabigatran. And you can see this increases with renal impairment. Therefore, in patients with renal impairment who may need urgent surgery, for example, you have to realize that there will be a longer carryover effect of the DOAC in such a patient. And the onset of action is very rapid in all cases, that we get close to peak levels almost at 4 hours after the oral dose is being taken. Now, what about the data that supports a comparison of DOACs over warfarin? One could argue that warfarin is inexpensive and we have lots of experience with it, as a reason to use it compared to a DOAC. However, warfarin has a downside, as many of you will know. It requires the patient to go often to the lab. This is difficult for the elderly, and it has a narrow therapeutic range where patients can be stable for a long time and then either dip too low or too high from an INR perspective. We have a more steady state of anticoagulation and does not require monitoring when we use DOAC. So when we look at randomized trials that have compared warfarin to the DOACs in certain conditions such as atrial fibrillation, we do see comparable and in some cases superior efficacy of the DOAC compared to warfarin. This is shown for recurrent stroke and then fatal stroke, a similar pattern. So many of our trials are showing us that these DOACs are as effective, if not more so, than the DOACs. Then the downside of any anticoagulant is bleeding. So what about bleeding? And that's quite problematic with warfarin, where we do see patients on long-term warfarin have a constant risk of intracranial hemorrhage that does increase in certain scenarios, such as advancing age. And so when we look at the most feared safety complications, such as major bleeding and fatal major bleeding that include intracranial hemorrhage, we do see a lower bleeding risk for patients treated with DOACs compared to warfarin. So this is very attractive. Even though many patients express worry that the direct orals don't have a reversal agent, which is only partially true, we justify using them based on the ease of use, the broader therapeutic range, the equal, if not better, efficacy, and the reduced serious major bleeding that a patient may face. Now, there have been trials to test the agents that have been developed to reverse the effect of certain DOACs. The idarosuzumab, which is a monoclonal antibody to the dabigatran, has been shown in randomized trials to essentially soak up the dabigatran, and then we see a reduced bleeding rate and risk. Most commonly, we have a scenario of an elderly patient on dabigatran who, for example, maybe in a motor vehicle accident, comes to the emergency room, has head trauma. What do? Now we are giving this 5 grams intravenously to such a patient, reversing the effect of dabigatran, minimizing the impact of the trauma, and then if they need to go to the operating room, off they go. For the oral 10A inhibitors, there have been a few randomized trials and still some ongoing, essentially showing that we can inhibit the effect of factor 10A with andexanet alpha, and this has been shown to reverse the effects of apixaban and rivaroxaban for life-threatening or uncontrolled bleeding, and the dosing is dependent on the 10A inhibitor and the time of last dose. And it has been approved in the United States and Europe. We don't have the approval yet in Canada, and there are lots of considerations with respect to cost. If institutions do not have access to reversal agents, the standard default is the use of something called prothrombin cell concentrate, for which there are some observational data supporting their benefit, but what is lacking are robust randomized trials. Now, coming to the peripheral artery disease patients I mentioned, for 2 decades, we've really only been able to treat patients with PAD with a single antiplatelet agent, and that's what you would see in the guidelines of 2016-2017. There have been many trials in PAD patients trying to improve upon single antiplatelet therapy, including one that I conducted called the WAVE trial, where we tried full-dose anticoagulation with warfarin used together with aspirin. The balance in PAD patients is to minimize risk of cardiovascular events, including limb events, and minimize the impact of bleeding. Unfortunately, with full-dose anticoagulation and aspirin, we observed no significant reduction in ischemic events and a 2.5-fold increase in life-threatening bleeding, including intracranial hemorrhage. So we know that single antiplatelet therapy was the standard of care. Higher or moderate to high intensity anticoagulation with warfarin was too risky. And then in the middle of the slide, you can see the names of trials that have either tried to double up on antiplatelets, use more potent antiplatelets, or in the case of where we've hit what I call the sweet spot, the Compass and Voyager trial, both testing 1/4 of a full dose of a DOAC, in particular rivaroxaban at 2.5 milligrams BID, together with aspirin, in the prevention of MACE as well as the limb outcomes. And this combination was tested and shown to be effective in acute coronary syndromes, and then we tested it in chronic stable vascular disease. And this really was getting at a dual pathway inhibition with the antiplatelet impacting and preventing platelet activation and the anticoagulant at low dose preventing the generation of thrombin. And when we place the Compass and the Voyager trial side by side, you can see in both cases we have a significant reduction in recurrent vascular events with the low-dose rivaroxaban and aspirin in the Compass trial. The risk reduction was 28%. The Voyager trial was slightly different patient population. These were patients who had lower extremity PAD within 10 days of infrainguinal revascularization, and the low-dose rivaroxaban and aspirin was effective and associated with a 15% risk reduction in favor of this combination. So two slightly different PAD populations, consistent benefit makes the story quite believable. So to conclude, DOACs have revolutionized the care of patients with thrombosis. We can now treat many of our patients with thrombosis as outpatients. The bleeding is a risk with any anticoagulant, but we see the DOACs have less intracranial hemorrhage than warfarin. Reversal agents are now available in many countries, but not all. DOACs shouldn't be used in some conditions, such as mechanical valves. And low-dose DOACs used together with antiplatelet agents are effective in treating patients with chronic vascular disease. And now there are a new class of medications being developed in early trials called factor 11 inhibitors, which appear to be effective and have less bleeding compared to factor 10A inhibitors. So I'd like to thank you for your attention, and it's a pleasure to share my thoughts on this topic with you. Yours sincerely.